Diving related issues, diving related emergencies. Diving from the shore or from a springboard forms an important part of swimming. The greatest hazard of this sport is the possibility of striking the head against something solid, like a floor or like a rock or the floor of the swimming pool. What to do? The person coming to the victim's rescue should restrain the impulse to get the diver out of the water quickly, for there is grave danger that the neck may have been injured, even broken. Should the victim be pulled out of the water, his spinal cord could be injured or even severed, thus condemning the injured person to lifelong paralysis. Instead of removing the victim quickly, let a good swimmer keep him afloat, lying on his back in the water, until help comes to support him properly and bring him out of the water without tension on his neck. If the victim has stopped breathing, it is even possible to administer mouth-to-mouth respiration while he is still floating in the water. To remove him from the water, place a rigid stretcher, a surfboard, a door, or a wooden plank under him and lift him gently, keeping his body motionless while he is placed in the ambulance, so there will be no additional damage to his neck or spinal cord. For further directions on handling this type of accident, see head injury farther on in this chapter. Deep diving. Equipment now available makes it possible for amateurs to dive to depths of more than 100 feet, 30 meters. It is estimated that scuba divers number at least 1 million in the United States alone. Possible failure of equipment which provides air or oxygen for the divers, danger of becoming entangled in weeds or caught in rocks, and the possibility that inexperienced divers will take risks greater than justified, make drowning the principal cause of death in underwater accidents. Decompression, sickness, the bends. Those who dive to depths of greater than 30 feet, 10 meters, face the danger of decompression, sickness, Chiasson disease, and its possible serious consequences. This problem occurs when a diver remains too long at great depths, and then ascends to the surface without allowing sufficient time for the gases dissolved in the fluid of his body to reach a new equilibrium. Thus bubbles of gas develop in his tissues and may cause serious after effects. Symptoms of decompression sickness include pain in the joints, pain in the chest, with cough and difficult breathing, paralysis of certain muscles, disturbances of vision, and dizziness. These beginning to appear soon after the diver emerges from the water. Treatment of decompression sickness involves use of pressure equipment, which may not be easily available. The victim is placed in a tank constructed for this purpose, and the air pressure within this tank is increased to simulate the pressure to which he was subjected while diving. This pressure is gradually reduced over a period of a few hours, allowing the patient's tissues to make a gradual adjustment. Official lifeguards and other authorities in areas where diving is common are usually informed on the location of this type of equipment and can help in transporting the victim of decompression sickness to such a center. Drowning. Swimming and diving are such popular sports that drowning is listed as America's fourth leading cause of accidental death, accounting for about 7,000 casualties per year. A swimmer in danger of drowning often panics, making it dangerous for other swimmers, even those skilled, to attempt a rescue, lest the floundering swimmer cling to him so tenaciously as to pull him to under the water. Better, therefore, than to attempt a person-to-person rescue is to throw the imperiled swimmer a rope or a life preserver or reach for him with an oar or pole. If the person in danger has been injured while in the water, great caution should be used in removing him. It is relatively easy to keep the average person afloat with his mouth and nose above water. However, once attempt is made to remove him, the buoyancy which the water imparts is lost, and the struggle to lift him may even aggravate his injury. It is sometimes better, therefore, to keep an injured person afloat until suitable equipment arrives, even though this may mean administering mouth-to-mouth respiration while the victim is still in the water. The acceptable way to remove an injured person from the water is to place a firm stretcher or wooden door or wide plank underneath him to keep his body straight while he's being lifted out of the water. Obviously, prevention is the best means of combating drowning. Every intelligent person, child as well as adult, needs to cooperate carefully in all safety rules for swimmers. Many factors may contribute to the hazard of drowning, even with experienced swimmers. One formerly mysterious but now understood is hyperventilation. This danger threatens a swimmer when he takes several deep breaths just before swimming underwater, thereby releasing from his body a large portion of carbon dioxide, which under normal circumstances would stimulate his continued breathing. Thus, the swimmer loses his desire to breathe and falls in danger of losing consciousness while still holding his breath. Another circumstance in which this same tragic series of events may occur is that of diving repeatedly with every short time interval between dives. Here again, the diver may breathe so vigorously between dives as to nearly rid his body of carbon dioxide and thus lose his urge to breathe to the extent that he loses consciousness while underwater rather than surfacing for another breath. What to do? If there is anyone else at the scene, send him at once to summon help, preferably a rescue squad. Do not leave the victim yourself, but stay with him and keep him breathing. Keep the victim breathing This is the rescuer's primary occupation, and he must work to this end, even while the victim is still in the water, and even while he is being transported to hospital care. For hospital care, if the victim is still breathing on his own, well and good. If not, artificial respiration must be administered as outlined below. Begin artificial respiration at once if the victim is not breathing. Allow not more than 10 seconds for cleaning debris or mucus or water out of the victim's mouth, and then begin mouth-to-mouth resuscitation. Place the victim's head in extension, chin up as illustrated. This tends to keep the air passages open so that air can enter his lungs. Fill your own lungs with air and then breathe into the victim's mouth while holding his nostrils closed, either by your cheek against the opening or by your thumb and finger. This should cause the victim's chest to expand. If the victim is a child, remember that the capacity of his lungs is small. Be careful, therefore, not to overinflate them, but give small, short puffs. Do not waste time trying to get water out of the victim's lungs before you begin to breathe into his mouth. In mouth-to-mouth artificial respiration, the victim's chin is kept tilted upward. If the victim's mouth is clenched shut, as sometimes occurs in the case of a drowning person, separate his lips and breathe into his mouth anyway, allowing your breath to pass between his teeth. After filling the victim's lungs with your own breath, take your mouth away from his while he expels this air. This he will do on his own without your having to compress his chest, and even though he is unconscious. Be alert to the possibility that the victim may vomit. If he does, simply turn his head to one side, clean out his mouth as quickly as possible, and continue breathing air into his lungs. Vomiting simply indicates that the victim is short on oxygen. Furthermore, he may have swallowed considerable water which is now being regurgitated. It is common for a drowning person to have a convulsion. Do not let this alarm you, and do not let it interrupt the mouth-to-mouth resuscitation any longer than absolutely necessary. When the rescue squad arrives, allow those with experience to take over, giving artificial respiration, a task usually accomplished by a mechanical device or administering pure oxygen to the victim. While continuing mouth-to-mouth respiration, feel height on the side of the victim's neck for the pulsation of his carotid arteries. If you feel none, presumably the victim's heart has stopped. It then becomes necessary for you or someone helping you to stimulate heart action. This is done by placing the heel of one hand, reinforced by the heel of the other on top of it, over the lower part of the victim's breastbone, applying pressure about once every second, sufficiently firm to depress the breastbone approximately 2 inches. Relax the pressure completely between strokes. If the victim is a baby, be gentle. in order to make sure that you are timing the application of your pressure correctly, count out loud. 1 little second, 2 little second, 3 little seconds, etc. If you have an assistant, make sure that the mouth-to-mouth breathing is not interrupted during this procedure. If you are working alone, compress the breastbone 12 times and then take time out to blow air into the victim's lungs 2 times. Then repeat this procedure. The attempt to revive the victim of drowning should be continued for at least an hour before giving him up as dead. A person who has been rescued from drowning in salt water has suffered the loss of body fluid because of osmotic action of salt water. He therefore needs to have water administered to him by mouth. In a freshwater accident, the rescued person is not in need of additional water. Even when a person is saved from drowning and begins to breathe on his own, nursing care, preferably in a hospital, will be necessary for many hours after the incident. Many persons who have been saved from drowning remain seriously ill for many hours or even days after the incident. During this time, they need careful supervision by a physician handling emergencies.